So first of all, great talks before me. And I have to say that every lucrative conference needs a confusing lecture, so that's my role here. So I'm going to be giving a confusing lecture because if you want a clear-cut answer into the psychiatric outcomes of cannabis use, you're going to be disappointed anyway. So what we're going to do today is at least try to find out why it's so complex, what we do know, and what we have to do in order to promote the field further. Because we are in a very confusing state having to do with the psychiatric outcomes of cannabis use. On the one hand, we have repeated reports that cannabis causes psychosis, and it's been shown in several observational studies. And on the other hand, we have both clinical reports and some clinical reports that it can be extremely beneficial for the treatment of PTSD. So is it good or is it bad? So that's going to be the topic for our talk today. A, is it detrimental to mental health or is it beneficial to mental health? B, why should we even care? Why is it that important for us? And C, why is it such a difficult question to answer? So we're going to be focusing on three specific psychiatric disorders, not because they're the most important ones, because it's going to be a window to help us discover what the methodological challenges are and what the current state of the knowledge is. So we're going to be talking about psychosis or schizophrenia, we're going to be talking about depression, and we're going to be talking about PTSD. So 30 seconds on Research Methodology 101. And this is important because the two previous speakers indicated that case reports aren't as powerful as longitudinal observational studies, which aren't as powerful as randomized control trials, which aren't as powerful as systematic reviews and meta-analyses. And this is important because there is a clear hierarchy into the level of evidence. When we say it's been proven that, we have to be very cautious. It's just a bit like rock, paper, scissors. That rock wins over scissors and paper wins over rock. So systematic reviews always trump everything else, depending on the individual studies that they include. Randomized control studies are better than observational studies, and basically most about everything is better than case reports. And this is important because when you want to discover what the negative effects of something is, then observational studies are actually enough. When Sir Bradford Hill, the British epidemiologist, set out to explore whether nicotine or tobacco smoking causes lung cancer, he relied on observational studies. So when you want to discover a negative effect, observational studies are enough. When you want to discover a positive effect, though, observational studies aren't enough, and you need clinical trials, preferably randomized control studies. So this is a big difference, and throughout the lecture we're going to be asking ourselves, so did this come out of a case report? Did it come out of observational studies? Or is it a randomized control trial, or better yet, a systematic review or meta-analysis? So the whole issue of cannabis and psychiatry shouldn't surprise anyone, being that psychiatry is in the brain and CB1 receptors are widespread throughout the brain. But it also has to do with something called listening to the client. More and more clients coming in, especially as the potency of cannabis has increased, as THC concentrations have increased, more and more clients coming in saying, listen, doc, when I smoke, I become a bit more paranoid. I'm not totally delusional, and I have insight, but you know, there's a knock on the door and I'm saying, hey, maybe it's the police. I'm not totally hallucinating, but I'm kind of maybe hearing things, kind of illusions. So first of all, we do listen to our clients. And even when we infuse THC intravenously to healthy subjects, we see that there is a transient increase in psychotic symptoms. Healthy subjects, not susceptible individuals and not individuals with schizophrenia. So that does mean that there is an association between acute administration of THC and soft or not so soft psychotic symptoms. But that doesn't mean anything in terms of psychiatric disorders because that's transient and it subsides within 2 hours, sometimes 3 hours. We're interested in the long-term effects. And the whole story of the long-term effects is the cannabis and psychiatric disorder started in the 80s with a group of individuals from Sweden that published in The Lancet the first longitudinal study. It was a cohort study indicating that if I started using cannabis in adolescence and I used it enough, meaning at least 50 times, that I'm at a 6-fold increase in my risk for schizophrenia. Again, so if I started using it very young, under the age of 16 usually, and I use it enough, then I'm at an increase for developing a psychotic disorder, specifically schizophrenia. Now, Swedish conscripts are good, Swedish registries are good because A, there's a mandatory army service, which means that they enroll everyone at age 16 and give them psychometric exams, and B, there's a public health system so you can link data. So that was the first study coming out in 1987, indicating that maybe we should be cautious, that maybe cannabis can induce psychosis or a psychotic disorder in the general population, perhaps among susceptible individuals. But remember that I told you that cohort studies or longitudinal studies are not as good as randomized control studies and not as good as meta-analyses. So we were waiting for the meta-analyses that finally came out in 2007, and it's true that it's been over a decade, but it's still the best meta-analysis to date on the association between cannabis use and psychotic disorder. And it was conducted by Theresa Moore and Stan Zammit and a group of individuals from Britain, indicating that individuals who use cannabis are at an increased risk for developing a chronic psychotic disorder. How much increased? A 1.4-fold increase. Now, this is where it starts to become complicated or complex. Because while it's true that individuals who use cannabis are at increased risk for developing a psychotic disorder, and while it's true that the increase is 1.4-fold, meaning about a 40% increase, now we have to decide how we tell the story. You can tell two different stories based on the same scientific truth. On the one hand, the media can say, and it's true, that the increase is a 40% increase. On the other hand, when you take into account what the prevalence of schizophrenia is in the general population, it's 1%. So if you have a 40% increase, you increase the risk from 1% to 1.4%. And now you can tell the story using two very different narratives. One saying individuals who use cannabis are at an almost 50% increased chance for developing psychosis, which is true based on the data. Or you can say, if at the end of the day it increases the chance to about 1.4%, then more than 98.5% of the individuals using cannabis will never suffer from a psychotic disorder. Both are right, both are based on the same scientific evidence, two different narratives using the same scientific facts. And now it's where it becomes a bit more complicated. The majority of individuals in different countries, depending where you are, mix their cannabis with tobacco. In a meta-analysis a while ago indicated that tobacco use increases the risk for psychosis 2.2-fold. So now it's becoming really complicated. So tobacco use increases the risk of psychosis 2.2-fold. Cannabis use increases the risk of psychosis 1.4-fold. Is it maybe even protective? Challenge number one. Challenge number two is that we know that as time goes on, the prevalence of cannabis use is increasing. The potency of cannabis is increasing. If cannabis use induces or causes schizophrenia, what do you think we'd expect? A lot of schizophrenia. But what's happened to the prevalence of schizophrenia in the general population since? Basically nothing. So more individuals smoking more potent cannabis, higher THC content, and the prevalence of schizophrenia basically hasn't changed. Again, a bit complicated. The third thing is that we're in an era of personalized medicine. What we're asking ourselves today is not what the effect of any kind of exposure variable is on the general population, but rather, are there specific individuals that are susceptible to develop a disorder? Now, I want to say beforehand, this is a great study of Shalom Caspi conducted out of London. It has not been replicated, even though it's been tried, so you shouldn't regard this as scientific truth, but it does point us in the right direction. What Caspi discovered at the time is that individuals who have a certain variant of an enzyme called COMT, which is related to the degradation and metabolism of dopamine, if specific individuals, here on the right-hand side, start using cannabis in adolescence, and they have a specific variant of the gene for COMT, they are at an extremely increased risk for developing psychosis. But if you don't have that gene, then you're not susceptible to develop psychosis under the influence of cannabis. So again, we see a general effect size in the population. We have to ask ourselves, okay, but the population is actually built of specific subgroups, and maybe there's a small group that's susceptible, and if we can target them beforehand, we can tell the rest of the individuals that it may be safe for them. And the last thing is that these are observational studies, and one of the bad things, or one of the problematic things in observational studies, is that we don't know what people are smoking. Just for an example, there are two very different indications relating to the association between cannabis use and psychosis. This good study came out showing that the higher the content of THC in the smoked cannabis, the higher the chance of psychosis. They chose to define high-potency cannabis as more than 10% THC. I'm not sure it's reasonable today, but they did show that on the one hand, THC is probably a cause for psychosis among susceptible individuals. On the other hand, a great systematic review coming out showing that CBD can actually, as a neuroprotective agent, can actually treat psychosis and even resistant psychosis. So we're starting to get a feel of how complex it is. You take a simple fact, like cannabis use may induce psychosis. We start thinking about the fact that, well, people mix cannabis with tobacco. That may have an impact. That some individuals may be more susceptible than others. That it really depends on what kind of cannabis is used and whether it's high CBD or high THC. But at the end of the day, regarding psychosis, it is reasonable to say that among individuals who are susceptible, which basically means those with a genetic construct and those with a first-degree family member suffering from a psychotic disorder, cannabis probably does increase the chance of developing schizophrenia. That THC-rich strains are probably more important in causing schizophrenia, and that CBD-rich strains may, as a neuroprotective agent, actually be a pretty good targeted therapy for psychosis and even for resistant psychosis. And the last thing is that in any case, just like in life, among cannabis users, tobacco should be refrained from in any case. So that was just an example regarding cannabis use and psychosis, something taking a very short line out of the Washington Post or the New York Times or any kind of media outlet and showing how much more complicated it actually is. I promise to be confusing. So, like I said at the outset, a good place to start is conducting a meta-analysis. And this is a meta-analysis I published a while ago regarding the association between cannabis use and depression. So conducting a meta-analysis is a kind of an excruciating process. You go over 4,000 different studies, and you try to take the studies that are relevant, high quality out. What we found at the time is that among individuals who use cannabis, the risk of developing, not having, but developing for the first time, depression is increased by about 1.2-fold. Now, depression is more prevalent than schizophrenia, so if you have about a 10% prevalence of depression, it's increased to about 12%, which on a global level, in terms of public health, in terms of economy, may be important. But one of the things about meta-analyses is that they are only as good as the individual studies that they include. And trying to be as stringent as possible, in that publication itself, in the discussion, I actually mentioned why I was discontent and why I was concerned with the results, thinking that there may be a better way to explore this question. The first thing is, and again, this is a research 101 for 30 seconds, when you try to explore the association between any kind of exposure, let's say cannabis, and any kind of outcome, let's say depression, you have to take into account a lot of what we call confounding variables. Confounding variables are variables that may be associated with both the exposure and the outcome and may give the illusion that there's a causal association. So, for example, among the confounding variables, early adverse events, early trauma, PTSD, child neglect, are associated both with increased initiation of cannabis use and increased risk for depression. Other psychiatric disorders, such as anxiety, are associated with both cannabis and depression. Other use of substances is associated with both cannabis use and depression. One of the problems in our study, in the meta-analysis, is that some individual studies accounted for a lot of different confounders, while others almost disregarded them altogether, which means that the methodology of the meta-analysis was good, but the individual studies included in it were not as good. The second thing is that Bradford Hill taught us over half a century ago that in order for us to infer a causal relationship, we need something called biological plausibility. Does it even make sense? Is there even any kind of biological mechanism by which we can understand why cannabis would cause depression? And I was a bit concerned with those results because I remember that a while ago, there was this wonder drug that some of you may have heard of, maybe some of you took it, called rimonabant. And rimonabant is the CB1 antagonist, so it blocks the activity on the CB1 receptor. And it was supposed to be a wonder drug because it did everything we wanted from a drug that works on the metabolic system. It reduces your bad cholesterol, it increases your good cholesterol. It reduces your triglyceride, it reduces your BMI, supposedly a wonder drug. So how come we're not all on rimonabant? Because it was taken off the market. And why was it taken off the market? Because it causes depression. So I started asking myself, okay, so does that make sense? Does it make sense that an antagonistic drug blocking CB1 receptors causes depression? and that an agonist like THC would also cause depression? We don't see that in medicine. We don't see that in science, that an antagonist and an agonist cause the same thing. So we went back to the drawing board with the same question, whether cannabis use causes depression, and using data on 34,000 individuals in a 3-year follow-up, we explored the question using some kind of bidirectional analysis, controlling for all kinds of confounders. So we did what you usually do. You build on previous research. In this case, it was my own research, but you build on previous research to try to improve, go back to the drawing board, and receive better answers. So the first thing we found is that, does cannabis use increase the risk for depression? When you do control for all the confounding factors that we realize you have to control for, the answer is no. And without getting into too much details, once the confidence interval crosses the 1, that's the right-hand number in brackets, then the answer is no, it's not significant. But we did a bidirectional analysis because we knew that cannabis use and depression go together. So we asked ourselves, well, maybe it's not that cannabis use increases depression, but rather that individuals with depression initiate cannabis more, and we found that that was exactly the case among those 34,000 individuals. So again, this is an observational longitudinal study, it's not an interventional study, but there is an association between cannabis use and depression. What we found is that it's not so much that it's not so much that cannabis use causes depression, but rather that individuals with depression initiate cannabis at a much higher rate. And this is not new. Ed Kansian, great psychiatrist, set forth the term self-medication in the 1970s, and he said, well, it makes sense. You know, people use substances, whether it's drugs or other substances, in order to relieve painful affects. So it makes sense that individuals with depression would use cannabis, maybe in order to alleviate their symptoms. The question is, how effective is it? So the next study we conducted is taking a group of individuals with depression who initiated cannabis and seeing whether it alleviated their psychiatric symptoms, and we didn't see that. Well, we did see that, generally speaking, didn't really matter that much. It actually aggravated very slightly 3 specific symptoms: anhedonia, psychomotor activity, and body weight. But generally speaking, it seems as if, to date, using observational data, even if it is a form of self-medication, not necessarily that effective. So again, we're just looking into a bit of some windows into different methodological issues. So what we can say here, just kind of almost as an anecdote regarding depression, is that when we take into account all the potential confounders, cannabis use does not increase the risk of developing depression, but depression does increase the risk of initiating cannabis use, that it doesn't seem to be that effective. And obviously, then we'll talk about strains and specific cannabinoids, etc. But the most perplexing thing is the association between cannabis and PTSD symptoms. So in Israel, for example, PTSD, post-traumatic stress disorder, is the only psychiatric indication for which a psychiatrist can actually prescribe medical marijuana. And on the one hand, I myself have several patients with PTSD who've benefited immensely from cannabis. And on the other hand, the research is not extremely unequivocal. So let's take a look at why it even started out in the first place. First of all, observational, clinical data, clients coming in, VA clients in the States, Army soldiers in Israel, coming in saying, listen, I took some cannabis off a friend, I've never felt better. I've been on SSRIs for 4 years, done therapy, haven't improved, used cannabis and I'm sleeping better. Can I get some cannabis through you? So a while ago in Israel, there was a study, Shaul Lev-Ran from Hebrew University conducted this one, that showed that specific cannabinoids can improve specific PTSD-related symptoms, particularly sleep and nightmares. But if you'll notice, the study that he came out with is not an observational study, it's a clinical study, but it doesn't use smoked cannabis, there's no entourage effect, it's only THC, delta-9 tetrahydrocannabinol, meaning that the first study relating to PTSD was not on smoked cannabis, but rather on one specific cannabinoid, as was the second good study. An additional study indicating that a synthetic CB1 agonist, Nabilon, a synthetic THC compound, reduces PTSD symptoms, that's on the left-hand side, and improves function, that's on the right-hand side. So supposedly, we have 2 good clinical studies indicating that specific cannabinoids can improve PTSD symptoms. But like I said, this is not smoked cannabis, no entourage effect. These are only specific molecules, CB1 agonists. And on the other hand, we have a study that came out about a year ago from, I believe it's about 11,000 individuals in the VA system in the States, indicating, this is an observational study, indicating that among PTSD clients who use cannabis, they're actually doing a bit worse in terms of violence, in terms of the severity and symptoms. So on the one hand, clinical studies showing that it's better, but again, using specific molecules. On the other hand, lower grade evidence, observational data, saying that it may actually be detrimental. And this is one of the most disconcerting slides. This came out, I think, in May of 2019, Journal of Dual Diagnosis. And it's a systematic review on the effect of cannabis and cannabinoids in the treatment of PTSD. And what it basically asks at the first part is, well, how good methodology, how good methodologically are these studies? And basically, red means low quality or high potential of bias. And this is a point of concern. Because if we don't have good studies, we're not going to be able to promote good medications. If we don't have good studies, we're not going to be able to promote good therapies for our clients. And when you look at it, even basic questions such as, was the exposure and outcome variable adequately ascertained? Was there a dose-response effect? Was the follow-up long enough? By and large, most studies regarding cannabinoids and PTSD received very low grades in terms of methodology, and that's a cause for concern. So generally speaking, when we look at the association between cannabis and PTSD symptoms, first of all, both personally, a lot of colleagues, a lot of case reports, a lot of case series, you see across the board that a lot of PTSD clients report improvement in PTSD symptoms. But looking at the scientific data, you see RCTs, which use a single molecule, which show effectivity, and you see observational studies using whole plant or general follow-up, which show potentially a negative effect. And the most important issue is that the quality of the studies across the board are generally relatively low. So going back to where we started, we said the pinnacle of scientific evidence is in meta-analyses and systematic review. And in October of 2019, just a month ago, this systematic review came out in Lancet Psychiatry, asking the question across the board, how effective are cannabinoids for the treatment of psychiatric disorders? So it's small print. I don't know how much you guys can see what's written on the left, but the numbers are important. So what they did is they took 4 categories of psychiatric disorders. They went over 1,673. That's a lot. 1,673 studies, or a lot of studies to go over on depression and anxiety. Almost 1,000 studies into ADHD and Tourette, over 1,000 studies of psychosis, and just under 250 studies relating to PTSD. So this is an extremely important systematic review, and the bottom line is a cause for concern. Because the bottom line is that there is scarce evidence to suggest that it improves psychiatric disorders, that there is insufficient evidence, and most importantly, this is, I think, a call for action, we need high-quality studies. When I show that pyramid of scientific evidence, what that means is that regardless of the field, no one's going to be able to use observational data and treat it like clinical data. Just like no one's going to be able to use a case report and treat it as a clinical study. So we need better evidence, we need higher quality studies. And this, in a way, is quite complex because there are several methodological issues that we have to take into account when we conduct these studies. The first is that age of onset of cannabis use is an extremely important factor when you try to take into account psychiatric outcomes. And that, a lot of times, is not accounted for. It has to do with the neurobiology and neurobiological development of the brain and the fact that the frontal lobes are the last thing that is developed. So while individuals start using cannabis at a very young age, 12, 13, 14, the reward system becomes dependent on cannabis for its dopamine, and by the time the frontal lobes come into action, it's almost a lost case. In several psychiatric disorders, for example, among young men, schizophrenia usually erupts at age 15 to 25. So you have an individual starting to use cannabis very early, that's a huge impact, and a lot of times that's not accounted for in clinical studies. The second thing that we have to account for in observational studies, and we're doing a terrible job at accounting for that, is that there is no standard dose. Now just imagine what we're talking about. We heard some important clinical trials, and I want to give you a picture of what an observational study looks like. An observational study is usually on a lot larger population, tens of thousands. So you ask an individual, so you do smoke cannabis? He says, yeah, I smoke cannabis. how many joints do you smoke per day? So the guy says 2 joints, 5 joints, 17 joints, doesn't really matter. But the issue is that no one knows what a joint is. So we're using a variable that supposedly is a numerical continuous variable that we pride ourselves on its value in research, whereas it has very little value. A joint can mean a teeny-weeny joint. It can mean a mega joint. We used to be in the same situation regarding alcohol, by the way. We just asked people, how many glasses of alcohol do you drink per day? 1, that's okay. But then we started discovering that it's important to standardize drinks. So today we have a standard drink. That means that about 14 grams of alcohol, regardless whether it's spirits, wine, beer, that we have some kind of standard dose. In cannabis, we don't have a standard dose, and that is a huge problem. Just to give you an anecdotal example, 2 guys rolling 2 joints using 2 very different strains, one high THC, one low THC, one rolling a large joint, one rolling a small joint, one using tobacco, the other not using tobacco. So the first individual will have an effective dose of about 0.42 grams of THC in his joint. The other guy will have 0.002. Both are going to answer, I smoked 1 joint today. So in terms of observational research, in terms of longitudinal accumulation of data, this is a highly challenging issue because it's more than 100-fold differences between the 2 joints in terms of THC content, and those 2 individuals are going to be in the same category in terms of our observational research. And the last thing is obviously the content. This is out of the British Journal of Psychiatry over 5 years ago, indicating that the higher the CBD content, the better the cognitive functions. And obviously these are only 2 cannabinoids out of over 100, CBD and THC. So in observational studies, we actually don't know what the individuals are using at all. So bottom line, is cannabis detrimental for mental health? Obviously, it depends. It depends on the disorder, what outcome are you looking at. It depends on the specific cannabinoid, like we said. For psychosis, high THC, probably it is. High CBD, probably actually neuroprotective. It depends on the dose, even though we don't know enough about that. And obviously, it depends on the individual's characteristics in terms of genetics and in terms of personality traits. But what can be done? And this is, I think, the more important part. First of all, I think that it's important for all of us as a social responsibility and for the industry to indicate that like any other thing that can be of value, it may have adverse effects. I actually believe that the fact that not enough individuals are talking about adverse effects is not helping to promote the field. In a lot of ways, it's drawing it back because every regulator wants to hear about what are the adverse effects and what are the prevalence. So I think we have to talk about the adverse effects, including talking about the prevalence, which generally speaking, regarding cannabis and related to a lot of other substances will generally be very low, but we have to talk about that part. That we do have to take particular caution with at-risk populations. So these are individuals with first-degree relatives with a psychotic disorder, generally speaking youth, and individuals with a very high susceptibility for addiction. Those are generally the 3 populations at risk. But I think more important from my perspective as a take-home message is that psychiatry in general is in dire needs of new compounds. We have saturated our use of monoamines, of another dopaminergic drug, another serotonergic drug, another noradrenergic drug. We are in dire need of additional compounds. The endocannabinoid system has not been tapped into adequately in psychiatry, far from it. But what we do need is better quality studies, and this is important. There will be very little benefit in including 2, 3, 5 more observational studies. We're saturated with those kind of studies, and you can't promote things further. We need RCTs. We need to target on specific cannabinoids, whether it be based on big data, AI, trial and error, whatever. We need better data, and we need set doses. Remember that pyramid. Remember where the pinnacle is. We have to make the leap from observational studies in psychiatry to RCTs in psychiatry. Generally, last thing, we don't have to focus on remission versus no remission, but I believe we should focus on specific symptoms. We all know that cannabis and cannabinoids can have non-specific effects, which may be extremely important for individuals with psychiatric disorders. If you have a PTSD client, and it doesn't necessarily bring about remission of all his PTSD symptoms, but he sleeps better at night and he has less nightmares, that is extremely beneficial. The way we conduct research has to include outcome measures which are not only diagnostic and not only remission versus relapse, but rather specific symptoms. Now, I have a deep belief that if we target specific symptoms, if we conduct proper RCTs, if use specific cannabinoids, generally speaking, probably higher CBD, lower THC compounds, and at the end of the day, if we produce better science, we will allow our patients a lot more benefit. Thanks for listening.